Look, we have had I'm not going to say unusually large number, because I'm sure when you've done these sort of presentations in the past, you've always had a large number of participants and people register, but we are heading for a very large number of participants today. So it's just taking me a little bit of time to register or admit everybody. And just so that nobody misses out, the normal format that we'd do is we'd talk about some other things of interest to people at the end. But what I might do today, just to throw you and Lockie completely, is to do a quick overview of some of one of our other business partnerships, which is insurance and compensation services, and a software solution that they are putting out in the marketplace, which I believe you have used, because when you've gone onto our platform to upload your dictation or download all the letters of instruction and things, that workflow, calendar integration and payments platform, which I'm sure you'd be a fan of as well, we have sold that to another company. And Lachlan is the head of sales and relationships, and he's quickly going to do an overview of the Mag Connect platform, which we used to go by, which is now called Insurance and Compensation Services. And Lockie is going to give everybody a quick overview of that. Only take up a few minutes, and it's only so that we can keep admitting people into the room here. And if Lockie, if you could just take the lead, and then I'll do the introduction to Evan for everybody, because I know that there's a lot of people really keen to hear the seminar today.
Absolutely. Thanks, Mark. I'll just share my screen very briefly. So as Mark mentioned, I'm Lachlan. I'm the head of relationships at Insurance and Compensation Services. And Insurance and Compensation Services, we deliver a range of software solutions to the insurance and the personal injury industry. We've got a flagship, what we call our Ics Connect platform, and that provides a class-leading workflow management system for all personal injury stakeholders. On the other side, on the side, we're working on some additional projects and some products, and we've got some telehealth solutions for law firms and specialists. We're working on some AI tools for claims management companies, and there's client-specific or client sector-specific platforms that we use, and these are all integrated with data and analytics tools to assist all the stakeholders in the personal injury industry, whether that's a law firm, a specialist, an insurance agency, to help people get back to work quicker, which is, I guess, the goal or the reason we're all here. I'll start with ICS Law Connect as one of our sector-specific platforms, and it's a fully customizable platform which assists law firms in their information gathering processes. So it provides modular service-based offerings, and we've got jurisdiction-specific communications and reminders. There's API integrations with government portals for evidence retrieval, as well as external stakeholder logins for the injured person or the client. Another one of our sector-specific platforms is ICS Insure Connect. This is our class-leading insurance software solution designed to improve return-to-work outcomes and increase work efficiencies for claims managers. Again, providing modular service-based offerings and a panel management functionality for insurance company specialists. There's a workflow and correspondence management system and an integrated telehealth solution. Another one of our sector-specific platforms which are assisting government agencies. So GovConnect is designed to allow government bodies at all levels to manage compensation claims at an excellent service standard to their employees, with a fully compliant document exchange platform, integrated worker communication solution to improve return to work outcomes, and integrated data and analytics tools to assist government bodies in understanding why certain things are happening at certain times. In addition to our ICS Connect and sector-specific platforms, we're developing additional solutions to assist the personal injury industry in improving efficiencies and stakeholder engagement. So we're looking at some AI projects on claims leakage and financial calculations. We've got some open source data and analysis projects to understand injury management, return to work outcomes, and other, I guess, interesting points of data which we're looking at. And then we're working on some integrated telehealth solutions between law firms and doctors to ensure that the assessment and interview process is as smooth as possible. That's all I wanted to go over today. I'll pass back over to Mark to introduce Dr. Dryson.
Yeah, thanks, Locke. Now, as you would all probably know, Dr. Dryson is a leader in the field of medico-legal reports, having done hundreds, possibly thousands of medico-legal reports in the many hundreds for MAG, and over his career, many thousands, I'm sure. So he comes to today's seminar with a wealth of not just clinical knowledge, but also knowledge about, what does the medico-legal report mean to the claimant, which is why we've probably had so many registered users for today. And today's topic being the effects of a mild head injury on return to work. Evan, if I can, would you mind giving us a quick sort of background to yourself and your accreditations, qualifications, and interest in the industry, and a little bit about how today's presentation came about, and what this might mean to you?
Yes, thanks. Well, I'm an occupational physician by training, and that means that I'm mostly interested in conditions that affect people at work, such as how do they get back to work, what sort of work they can do, and that's going to be part of the crux of my talk today. I've been involved in the past in research. I've been involved in the past in university lecturing. I've been involved in various government departments, and now at what you might call a more advanced age, I'm more comfortable just doing easy work, which is medico-legal work. To me, it is easy.
Okay, look, thanks for the introduction. I'll now pass over to you, and before I do that, though, I just want to thank you again for your commitment to the education of all the industry stakeholders. I know that this is quite time-consuming and takes a lot to put together, to coordinate, and so I'm very grateful, and I'm sure everybody in the room today is very appreciative of your time. And I've had a quick look at the presentation. I know it's going to be very interesting for everybody. Just by way of a few housekeeping preferences, I guess is the right word. Are you okay, Evan, if questions come up for people to ask as we go?
Yes, I am. I think that's a really good thing to do, because if people have got a question that they want to ask at the time, it means that they're interested, and I'm happy to answer as best I can.
Okay. So everybody, if you're happy for you to either unmute and just ask a question, or if you'd like to post the question in the chat, I'm happy to ask it on your behalf at any stage. So thank you again for today, Evan, and I'll hand over to you to share your screen and go through the presentation.
Thank you. So can I click on each one?
Mm-hmm. Can everyone see the screen?
Yep, it's not full screen, still got the prompts down the side there, G. Do the slideshow. There we go.
So you can either click on the mouse anywhere on the screen.
That brings the next one up.
Yeah.
Okay. Well, we're going to be talking about what's called TBI, which is traumatic brain injury. It's obvious that traumatic brain injury can be various different forms of severity, and indeed it's classified as mild, moderate, or severe. So the way that we work out how to classify a brain injury as mild, moderate, or severe, we use various tools. The first one is the Glasgow Coma score. Now, this is a way to estimate how much of a head injury there is in the first time when a patient is concussed. So the score is out of 15. So if you have a score of 15 out of 15, it means that you are fully conscious, you're fully alert, you're able to answer questions, and you don't have concussion. So there are three parts to the score. One is the eye-opening score, and the attending ambulance worker or doctor or nurse or whoever's there will check to see whether the eye is open, for example, at a spoken request. This is scored out of 1 up to 4. The next one is motor response, and that is scored from 1 to 6, and it depends on the various movements that are being undertaken. Obviously, if someone is completely unconscious, they're not moving at all, and they will score a 1, as I put there as an example. The last one is verbal response, and that means, does the patient respond to a spoken request? This is scored out of 5, 1 to 5, and I've given as an example there that if they only moan or groan in response to a verbal request, then you would score 2. So they're just examples, but you can see that you'll get a score anywhere between or anywhere up to 15. The next critical issue about a head injury is how long does someone suffer post-traumatic amnesia? So amnesia is, of course, inability to recall events. It's loss of memory, and it will occur immediately after a motor vehicle accident or a head injury or a fall or any other injury to the head. Sometimes there's a small period of anterograde amnesia, which means that the person may not actually remember the impact itself. And this is not uncommon. I ask my patients, say, if they've had a motor vehicle accident, do you remember the actual impact? And they might say, no, I remember screeching of brakes, I remember seeing the vehicle coming at me, but I don't recall the actual impact. So that is amnesia. Amnesia after the event can last for a length of time, which can be days or weeks sometimes. So the way that post-traumatic amnesia is measured is using the Westmead Pta Scale. This is a scale that was developed at Westmead Hospital here in Sydney. There are 12 questions. 7 of them assess the orientation. Where am I? Where are you? 5 of them assess the memory. What can you remember? So once the score is 12, it means that that person has left post-traumatic amnesia, and the hours or days following the accident are then calculated. So here's how we assess TBI severity, and we use the Glasgow Coma score, which we've just talked about. We use the length of post-traumatic amnesia, which we've just talked about, and we use the length of loss of consciousness. So a mild TBI, for example, has a Glasgow Coma score of above 13, post-traumatic amnesia of less than 1 day, and loss of consciousness of less than 30 minutes. Now, you will imagine that this is not always consistent. someone may have a loss of consciousness of less than 30 minutes, but have post-traumatic amnesia for greater than 1 day. So in the end, it's just a clinical assessment which fits best. Now, it's clear that the severity of the head injury is going to be related to the outcome. So more severe head injuries have more severe outcomes. We're not going to talk today about moderate TBI or severe TBI, but just the mild TBI. And you might think, well, not much in that, they're all going to get better. It's only mild after all, but there is a fishhook. And I'll come to that. It's called post-concussion syndrome. So the symptoms of mild TBI can be divided into 3 groups. The somatic symptoms, that's the body symptoms, and I've given some examples there: headache, dizziness, photophobia, which means intolerance to bright lights, and phonophobia, which means intolerance to loud noises. The second group are the cognitive symptoms, and I've given examples there, like decreased attention, decreased memory, decreased ability to multitask, and there are many more cognitive symptoms which can result as a case of mild TBI. Lastly, the affective symptoms, and I've given examples there: irritability, anxiety, and depression. Post-concussion syndrome is the big problem with mild TBI. These are people who go on reporting symptoms long after they should have ceased getting symptoms. It can go on for months, it can go on for years. You'll see here that some 10 to 20% of mild traumatic brain injury patients do report such symptoms. It's not clear why people get post-concussion syndrome. It's fair to say that it's even a controversial diagnosis. It could be due to physical damage, neurogenic damage, such as structural injury to the brain. And there's a condition called axonal shearing. This means that the axons, the long tails on the nerves, can be torn as a consequence of rapid acceleration and deceleration to the brain during a concussion. Other people think that it's all psychogenic, and there is some support for that. People with pre-morbid psychopathy, depression, anxiety, various other mental illnesses are more likely to keep on reporting symptoms long after it would have been expected that the symptoms would have gone. There are some psychosocial factors in the development of post-concussion syndrome, and these factors can contribute to a poorer outcome following an MTBI. So oddly enough, if you're unmarried, you're more likely to be employed at the end of 1 year, unemployed at the end of 1 year. Don't ask me why, this is just something that has been recognised. Educational levels are important. People with a lower level of education at the time of the TBI are more likely to be unemployed. Occupational skill level is fairly similar. Manual workers at the time of the TBI are more likely to be unemployed. There are other setbacks such as financial loss, loss of job, etc., which can also prolong symptoms. Involvement in litigation is also thought to prolong symptoms. So how do you assess how a person is affected following a traumatic brain injury? There is what's called a neuropsychological assessment. It is carried out by a neuropsychologist. Now, I am not a neuropsychologist. I just know about these assessments and I use them all the time in helping me to decide how to manage a case of TBI. So there's a series of tests which are administered to the person. They're comprehensive, they cover all of the cognitive domains. They are quite arduous, they take several hours to undertake. Sometimes patients find that they get fatigued just doing the tests. They have to be stopped and completed at another time. What the neuropsychologist will do to start with is to carry out what's called a pre-morbid estimate. That means what was this person likely to be like in terms of cognitive function before they had their head injury. Clearly important, because otherwise you have some measures of function. You don't know whether that represents what they were anyway, or whether it represents effects of the TBI. So the pre-morbid estimate is generally gathered by such things as educational attainment. There are other ways that this neuropsychologist will also put together an estimate of pre-morbid abilities. Then the tests themselves, they look at all sorts of areas of cognition. One important one is attention, which is the same as concentration. And it means how can this person at this time sustain their attention or concentration on any one particular task. Obviously, this is going to be important when we're looking at return to work. Another very important area of assessment is memory. Memory comes in various forms. There is long-term memory, there is short-term memory. There is working memory, which means information which is stored temporarily in the brain for the purposes of the current task and is then lost. So working memory is assessed by the neuropsychologist. Processing speed is very important. It means how fast can the injured person recognize a cue and respond. How fast is their brain working, in other words. Language abilities are assessed. Visuospatial means where things are in space. So it's important in people who need to be able to manipulate objects, for example. Executive functions are extremely important. And I've got a slide on executive functions, which is coming up. Basically, it means the ability of the brain to plan and to function. The neuropsychologist will also assess the person's mood. Are they depressed? Are they anxious? There are no particular tests for this, it's self-report. And they will assess the present symptoms expressed by the injured person. Now, you might be asking yourself, well, this is all very well, but how do we know that people are in fact answering genuinely? How do we know that they're not maybe slanting their answers to make it look as if they're worse than they are? And the answer is that it is possible to assess the validity of their performance. So there are certain tests which are not expected to be affected by a TBI. And if a person does badly in such a test, it is legitimate to ask whether or not they are genuinely trying. the neuropsychologist will also look at the results of the various tests. None of them measure a pure cognitive function, they all overlap. So the areas of overlap should be consistent from test to test. In other words, if the patient does very badly in one test and very well in another test, and there are overlapping functions in those two tests, it is legitimate to ask whether they are actually trying. So performance validity has to be done and must be done. And when you're looking at the results of a neuropsychological assessment, one of the first things that you do is to check to see that tests of performance have been carried out and that the neuropsychologist was satisfied that the client was being genuine. I said we'd talk about the executive functions. So the executive functions in the brain sit in the frontal lobe. That's the lobe, obviously, in the front of the brain. It is, unfortunately, one of the areas of the brain which is often affected in a TBI. So the frontal lobe impairments include the following list. So planning is undertaken in the frontal lobe. The ability to prioritize tasks is located in the frontal lobe. The ability to solve problems is seated in the frontal lobe. So if you have frontal lobe impairment, you're going to have problems with organizing yourself, planning, solving problems, and this is clearly going to affect your ability to return to work, which requires these sorts of features. Another major problem with frontal lobe functions is the effect that it has on people's impulsivity. So impulsivity goes up, inhibition goes down. This means that people with frontal lobe impairments are less able to control themselves. You can see that this may well have a significant impact on return to work. So after a head injury, and that there maybe has been some impairments discovered on neuropsychological testing, what happens then? Well, you expect the impairments to recover, and in most cases they do. Recovery can be slow, but generally all recovery that's going to take place will have done so at the end of 1 year. Neuropsychological test impairments still present at the end of 1 year are likely to be permanent. The only way you can find out whether they're still present, of course, is to repeat the neuropsychological tests. So it's been shown that people who have multiple neuropsychological tests actually get better at doing it because they're familiar with the tests that are used and it's no longer an unknown to them. So when a test is repeated, it is usual to use tests which were different to the first neuropsychological testing, but which test the same parameter. You're either going to do a full reevaluation, which is, in my view, the best way of assessing recovery or not, or you can just re-administer tests which you expect are likely to be able to be changed and don't do the whole battery of tests again. You don't need to keep on doing this. After a year, it's not going to change, and there is just no point in doing the testing anymore. So here are some of the behavioural changes after Mtbi. We've already talked about the frontal lobe effects on inhibition and We can also talk about problems with frustration, problems with anger and aggressiveness, difficulties in self-control, mood swings, and lack of social judgment. So again, you expect these all to improve after most cases of MTBI, but in some cases they do not. Clearly, it's going to be necessary for anyone who's had an MTBI to have a psychiatric assessment, and this may need to be done repeatedly. Some physical effects of MTBI. One of the most important is impairment in balance, and as you can see, this is not uncommon. It can occur in 40 to 60% of cases. What causes the balance problems? Well, it is known that concussion to the vestibular apparatus in the inner ear can cause balance problems, either by dislodgement of small sensory organs called otoliths, which produces a condition called benign paroxysmal positional vertigo. That means dizziness when you get up, dizziness when you turn your head. Usually this settles, sometimes it doesn't. Another possibility is what is called labyrinthine concussion, which just means that the labyrinth has been so shaken up that it is not functioning properly. It is also possible that balance impairment can be due to psychological reasons. It could be psychogenic. So now we're going to talk about the effects of mild TBI on the ability to return to work. So we're really interested here in people that already were employed at the time of the injury, whether they can get back to the same job or a similar job or a modified job in the same sort of area. I've brought up here a couple of studies which has looked at this. So a study by Silverberg and her associates showed that people with MTBI who were employed at the time of the injury, 58% of them achieve a return to work. Now that's not high, is it? It's 60%. You would expect after a mild head injury, if it was mild, that more people would get back to work than that. But that's one of the studies that show that MTBI can really affect return to work.
Evan, apologies for the interruption, but we had a question, and yes. I think it might have referred to a previous slide.
Okay.
But the question was from Jamie Shine, and it was, is it correct that cochlear labyrinth concussions do not resolve?
I would love to be able to answer that, but I regret it's outside my area of expertise. I think it's possible that sometimes they do not. I'm not sure on that. Okay. Sorry to be uncertain. The second study I just want to point you to today is by Thiedem and Associates out of Auckland University, so not far away. And they did a study looking at people who, whether they returned to work after 4 years following a mild TBI. So they found that 19 out of 110 of their study group had actually left the workforce. So I'm not sure what the percentage is there. It's a little bit less than 19%, obviously about 17%, I guess. And they were unable to return to work. They found that 17 out of 110, although they had returned to work, had to make changes to their workplace. And here are some examples. Reliance on note-taking. And I must say in my own practice that I find this is quite common. People who appear to have returned to work and made a good recovery from their TBI still have memory problems. They have to rely on diaries, making notes. Otherwise, they forget things. Allowing more time. That means that they are slower at doing the tasks that they had previously been doing. This comes back to what we looked at before, items such as speed of information processing, but it will also be affected by items such as impaired concentration and attention. Increasing breaks. This means that people are stopping and starting instead of staying with the task. It is clear that TBI can cause impaired function even after people have returned fully to work. Lastly, a lot of people can no longer work full hours and they will reduce their work hours. So you remember I was talking about the various symptoms in TBI, the somatic and the affective and the psychological. So if we have a look at some of the somatic symptoms such as a balance disorder or vertigo, how might that affect the ability of people to go back to work? Well, it's obvious they can't work at heights anymore. You don't want someone getting dizzy and falling off a ladder. They can't work on scaffolds. You can probably think of other areas where vertigo or a balance disorder is going to impair their ability to return to work. So what we do with a assessment of return to work function is we look at the actual tasks of the job, such as climbing ladders. We look at the specific impairments that the person has, such as a balance disorder, and we match the two together. So in that case, you would have to say that this person cannot return to their previous work climbing ladders. Another example is intolerance to loud noises and intolerance to bright lights. So maybe you can't return to a noisy office if it's an open plan office. Maybe you need to look at some form of seclusion so that you're in an office which is quiet and away from other people. You may have glare from windows. Maybe you need to look at putting up screens. Maybe you need to look at where the screens, the monitors are placed so that people are protected from glare and noise which affects their ability to function. By the way, it's very common, people who have photophobia tell me that they wear their sunnies all the time. Outdoors, of course, but even sometimes indoors. So cognitive symptoms and return to work. We might be looking, for example, at people who have been shown to have impaired memory or impaired attention and concentration. What does that mean for return to work? Well, if they're working in work of high cognitive demand, they're not going to be able to return to that sort of work. Doesn't matter how motivated they are, they won't be able to cope with the demands. They're going to have to look at downgrading, returning to work at a lower level of cognitive demand. They may, before the injury, have been working with deadlines and coping well, but now they're not going to be able to cope with deadlines, and allowances will have to be made for that in their return to work. Affective symptoms. If someone has a frontal lobe impairment, they're going to be impulsive, they're going to be unable to control themselves, they're going to be inappropriate. They're not going to be able to return to any sort of work which involves dealing with the public. I've seen this happen many times. The first time that there's any small disagreement with a client, a member of the public, a customer, they lose their temper. You can't do that. It's not good for business. Their employers aren't happy about that, and they have to lose their job. Working in teams, if you're not going to be able to pull together in a team, if you're going to be irritable with people who have differing opinions, if you're going to get angry, if you're impulsive, you aren't going to be able to work in teams for the future. High-risk environments, if you're impulsive, you may do something to put yourself or other people at risk. You can't return to work in a high-risk environment. So these are all areas where someone like myself, as an occupational physician, has to look at what the impairments are and match them against the tasks of the particular job that that person is either doing or is proposing to return to. If there is a mismatch, something has to give. The person will have to downgrade, change their job, even retrain, but they're not going to be able to return in a sustainable manner to their pre-injury job. So that's my presentation. I'm very happy to take any questions from this point.
Thank you very kindly. Very informative. Do we have any questions of anyone?
Yes, I have two questions. John Frommer here. One is, if somebody has trauma to the head but does not become unconscious, I would presume that they would still be able to have the same injuries, but to a lesser degree and less frequently. That's my first question. My second question is, people who have minor but frequent, or at least several minor effects of trauma resulting in either unconsciousness or not having unconsciousness, will develop or may develop over the years some degree of chronic encephalopathy, as for example shown by some sports.
Yes, they're very good questions. The first one was, if someone is not actually unconscious, can they still have effects of a traumatic brain injury? And the answer is most definitely yes, they can. There is some, I mentioned this business of axonal shearing. So there is some thought that if the brain just gets shaken up, and this is particularly seen, say, in the case of a motor vehicle accident where someone is rear-ended and may be pushed into the car in front, for example, so the head lurches backwards and then forwards and then backwards again. No unconsciousness results, but there is certainly damage to the fine structures of the brain, the axons. This will cause TBI symptoms, even though there's no unconsciousness. I might point out at this stage that investigations like CT scan or MRI scan will not show such axonal damage. So CT scans are used mostly for assessing whether there's a hemorrhage or a fracture, but that's looking at the severe head injuries, and we're not talking about that today. The second question, talking about repeated minor TBI, and the answer is that these are cumulative. So one of the things that it's important to ask anyone who's had a TBI is, have you had episodes of concussion in the past? If they have, then repeated concussions are more likely to be symptomatic and are more likely to be prolonged. In other words, take longer to recover. So the first time they may have bounced back with not much in the way of impairments. The second time they may have had more symptoms and took longer to get better. If they keep on getting concussions, and you rightly pointed out the encephalopathy, they can become permanently impaired.
Thanks for that, Evan. I believe Jamie's got another question. Just feel free to unmute and go ahead, Jamie.
Yes,
Yeah,
Jamie.
thanks for that. Just following on the discussion of scans, it's particularly, so I work a lot in the field of, or purely in the form of head trauma, but focusing a lot with helping people with mild TBI.
Yes.
Have you had any, particularly in Australia, have we seen any advancements in terms of any scans that are detecting, particularly those diffuse axonal injuries or the shearing injuries, that can show that damage? So like is anyone typically using the DTI? Is anyone using SPEC, PET? I see Dr. Alan Pearce is using the TMS. Like, are we taking that any further? Are we using that? Are you coming across those scans? I mean, from my perspective, I'm only seeing, normal CTs and if they're lucky, an MRI. So I'm certainly not seeing it, but I was wondering if you're seeing it at your level.
Yes, I agree with you. It's usually a CT scan. And I guess the reason for that is because you want to see if there's a fracture or a hemorrhage. MRI scans are not sufficient to show axonal damage, as you point out. I understand. I'm not a neuropsychologist and I'm not a neurologist, so all I'm dealing with is what's been put in front of me. And I haven't seen any more advanced scans. I understand that things like functional MRI can show such damage, but I personally have never been presented with anyone who's had anything like that to me.
Yeah. And can I also ask, so something I've seen a lot of in the US is the fact that pituitary gland damage, so dysfunction, is then also causing a lot of problems in the mild TBI cases. And that in turn is then impacting tests of effort in the neuropsychological assessments. Have you come across that?
I haven't seen any damage to the pituitary, no.
Okay. All right. Thank you, Doctor.
Yeah, they're pretty good questions, Jamie. Maybe we could pursue those at a later date with some of our other specialists, because I've been hosting a few concussion seminars recently with experts who, not dissimilar from yourself, are across what's happening in the US. And I think it's a pretty interesting space.
Yeah, definitely.
Especially when some of the major sports administrators settle without admitting any liability, and the evidence that goes with that is a little bit difficult to access, and is fine. It hasn't quite made its way here, but I think I know what your point is, and it's something we could probably all explore a little bit further with other seminars, because I know this one is particularly interesting. So maybe I can have a chat to you at a later date. We can find some other specialists that can add in. Maybe, Evan, you'd like to be part of a panel there.
Yeah.
This is a very topical area. So
yeah, Mark, that'd be great, because I'm specifically after experts that are in their field, such as endocrinologists, ENTs, neurologists, who specifically focus in the area of mild TBI. Because there's a lot in the US, but over in Australia, there are, I've been in contact with a fair few, but the more we could get on this, and particularly we can educate GPs and the treatment providers and get our clients connected quickly to multidisciplinary people that can actually assess and not refer them away if they haven't lost consciousness as a result of a coup contra coup injury or a rotational force injury. That'd be great.
It is interesting, possibly important for you to know, Jamie, that our software platform is being launched as we speak in the States, and we do now have access to doctors in that all over the US. I'm not sure how that evidence works from an Australian context, but happy to also explore that opportunity if it is an opportunity for you at a later date.
Yeah, if you can, I'll get in contact with you, Mark. That'd be great.
Okay.
Thank you.
Lots of questions coming in. I noticed before, Michelle, I saw your question come in, but Mr. CTP very politely put his hand up. and would like to ask a question. Go right ahead.
Ask a question regarding your field of position. Typically within...
Not a great connection there. Just wondering whether you could get a bit closer or maybe post the question if we can't hear you again.
I'm just moving away. Is this better? Is this a better reception?
Not really. No. Evan, can you hear that? I can't hear.
I didn't hear it. No, I didn't hear it.
How is it now? Is this any better?
No. Unfortunately, can't hear the question.
I might post it.
I'm not sure what the issue is.
I'll just post the question.
Yeah. Well, maybe you can post it. I might come back.
Is it better now?
Unfortunately not. I'm not quite sure what your name is, Mr. CTP, which is coming up on my screen, but I'll go to Michelle's question, and then if you could post yours, we'll come back and discuss it. Michelle says, Evan, a concern I've experienced, an insight from people with a head injury and the difficulty in engaging them in a change of employment, given all the symptoms you have flagged. Is that something you have resources that you could share?
I'm not sure, Michelle, what you mean by resources there.
Michelle, please feel free to elucidate.
What I was referring to with resources on, I guess, someone who has insight with people with a head injury and how to engage them into, I guess, getting some insight. For example, we might have an ambulance operator, they've sustained a head injury, they've been classified with an impairment of 70%, and they're adamant they want to return to ambulance operator and driver. And until they get 100% capacity, the employer's not interested. So how can we, I'm just finding out if you've got any resources where we could, I guess, explain that and assist the client with some insight, given all their symptoms, to sort of start, I guess, sowing a seed on having a change of career.
Yeah, it's a very important issue. I have to emphasise that I'm really just assessing people's impairments and making recommendations about fitness for work. So I don't actually undertake return to work programs myself. Obviously, people who have TBI are not always capable of having insight because of their injury. So the example that you gave is really interesting. You know, the expectation of this person is that they can get back to work where clearly they cannot. So how you get around this, I don't know. Clearly there are services which are important, such as psychologists, psychiatrists, head injury units and so on. But I don't have any personal experience with providing such resources myself. I'm sorry, Michelle.
Michelle, if you're able to send that question through to me as an email, we might be able to do something after today. Mr. CTP's question, Evan, during your medico-legal review, say 2 years post-injury, if a claimant has been certified totally unfit for work by their GP because they tell their GP they can't work, and a third party disputes that decision and wishes to obtain your opinion on past fitness for work, including the 2 years leading up to that date, make the determination for work, and are there any particular medical evidence you look for to make that determination?
Well, yes, Mr. CTP, it comes back to this idea of doing the neuropsychological testing, because that is an objective measure of the ability of this person to function cognitively. Now, I said that after a year, you're not likely to expect much in the way of change in cognitive function. So if this person has never actually had a neuropsychological assessment and it's 2 years after the injury, it's still valid to do it, because you're going to find out what their function is like now. What we're looking at in this person's case is, are they actually able to return to work now? So my answer would be, get a neuropsychological assessment done.
Does that answer your question? Prefer not to continue to call you Mr. CTP, but that's all I've got to go by at the moment. Does that sufficiently answer that question?
Yes, it does. It was just a general question before, but the neuropsych assessment definitely helps for that. Thank you.
Yeah, couldn't get that at all. Did you get that, Evan?
No, I didn't get it.
Okay. Sorry, we couldn't answer the question, but if you wanted to send it to me or post it again, happy to continue that. Now, another question that's been posted directly here, Evan, is does post-concussion syndrome symptoms ever go away?
And it's a good question. The answer is it's expected to go away and would normally go away within a few months. If it doesn't go away after a few months, you need to start looking at possible reasons why, and that would include getting a psychiatric assessment to determine whether there are any psychiatric reasons for perpetuation of symptoms.
Okay, thanks for that. Mindful of the time, and we've been going for an hour, and that people probably got to get on. I'm sure there's other questions. If you do want to post any other questions, feel free to send them to me, and I'd be happy to facilitate a further discussion with Dr. Dryson at any stage. Can I just take the opportunity again to thank you for your time, Evan? It's really, really much appreciated. With your permission, we will distribute today's presentation to the participants. And with your permission, we would post the recording to those that have requested it after. I'm sure you may need any sort of editorial editing of the video, but thanks again. There is for James. Yeah, okay, got that one. Thanks, Jamie. Any closing remarks, Evan?
Not at all. Thank you for giving me the opportunity. It's a really interesting subject, and I hope people found it informative.
Follow-up to it. I think there'll be a follow-up to it for sure. It's an area that is not just topical for return to work in a personal injury context, but there are lots of discussions in the sports world that I'm sure are constantly coming up. So thanks again for today. And of course, everybody will know that Dr. Dryson's available for impairment assessments across his range of accredited areas. Do you work in Queensland, Evan?
No, just New South Wales.
but you can do
I can do
law, motor vehicle accident, medical negligence,
yes,
workers' comp in Queensland, can't you? Yeah, because you're doing a lot of telehealth assessments.
I can do telehealth. Yes.
Yeah, yeah. So that's probably an area we could further expose you to. So I know most of your work is New South Wales. So thanks again, everybody. And we'll be in touch with the presentation and the PowerPoint that Evan's put together today. Thanks again, and bye for now.
Thank you.